So our ASTRO 2022 abstract is presenting a correlative analysis of MC1675, the DART study, which is a randomized trial of de-escalated adjuvant radiation therapy as compared to the standard of care. So treatment is delivered over 2 weeks in a de-escalated fashion as compared to 6 weeks. We looked at ctHPVDNA, or a blood-based biomarker, the NAVDX test, which reports TTMV for patients prior to surgery, after surgery, or 3 months after all treatment, including radiation. This was for any patient that had a plasma blood draw available. Prior to treatment, for the approximately 50 patients that had a blood draw available, we saw an approximate 90% rate of detectability in the blood. After surgery for these patients, that rate of detectability at this MRD time point fell to approximately 12%. Interestingly, patients that had residual ctHPVDNA or TTMV detectable in their blood were at higher risk of recurrence compared to those patients without any detectable ctDNA. The difference in PFS at 18 months was approximately 20%, meaning that this biomarker was highly significant for a patient's chance of recurrence. We went on to look at this within the patients just receiving de-escalated radiation therapy in an exploratory analysis. While this exploratory analysis was underpowered to reach statistical significance, most likely, it did show differences in PFS for patients that were treated with de-escalation, whether they had ctDNA detectable versus not. This time point is forming the basis of our upcoming phase 2 study, DART 2.0, which will be investigating stratifying patients for treatment selection of de-escalation or not based on the detection of ctDNA in their blood. So we think we can better select patients for this regimen of de-escalation based on this MRD time point. Our abstract went on to look at patients with a blood available 3 months post completion of treatment. We saw that the rate of detection at this time point was 7%, but provided an even more striking difference in PFS, where patients for the 7% that had detectable ctDNA had only a 25% chance of progression-free survival at 18 months, as compared to approximately 98% for patients that were ctDNA negative. Future work will look at, for those patients with ctDNA positivity at this 3-month time point, but without radiologic evidence of recurrence, are we able to escalate potentially their systemic therapy? These findings form the basis, again, of our upcoming study, DART 2.0, which additionally will look at patients undergoing chemoradiation. We believe that patients that are clearing their ctDNA mid-treatment or at approximately 4 weeks would also be candidates for de-escalating the total dose of radiation therapy. I'm happy to present these results today on behalf of all of my co-authors, as well as all of the patients who donated their plasma and enrolled in this phase 3 randomized trial, MC1675. I'm thankful to my primary mentor, Dr. Daniel Ma, who is the PI of this study. And we look forward to our next phases of trials based on this exciting data.